Welcome everyone to this masterclass on hCG, and this session is designed for both undergrads as well as postgraduate students. Now, for the purpose of convenience, I have divided this session into three parts. So today we'll be discussing about part 1, and it includes the basics, the source, composition, molecular structure, mechanism of action, and the dynamics of hCG. So let's begin from the scratch. First, we'll be decoding the terminology. Okay. So we're going to discuss about human chorionic gonadotropin. It's a hormone which is released from placenta. We all know, right? So human, we know Homo sapiens sapiens. Chorionic means something related to placenta, and then we have got gonadotropin. Okay, gonadotropin comprises of gonad plus tropin. Gonad, we all know, it is testis in case of male, and it is ovary in case of female. And tropins means growth. Okay, so it's a hormone released from placenta, and it promotes the growth of gonad. Now the question is, does it promote the growth of the gonad of the mother or the fetus in utero? And the answer is both. It promotes the growth of the gonad of both mother and fetus. Okay, now let's talk about the basic. First, the source of hCG. Now, mainly the hCG is secreted from the placenta, which cells syncytiotrophoblasts. But a very minor amount of hCG is also produced by fetal kidney. Okay, and we all know it's a glycoprotein. It's a hormone with the maximum amount of carbohydrate compound, and it's almost like 70% protein and 30% sugar or carbohydrate. Okay, now if you see the molecular structure of hCG, I want you to focus on this picture. Now, so hCG is a big hormone, okay, with a molecular weight of almost like 36,000 to 40,000 Dalton. It has got two subunits, alpha and beta. If you see the picture, you can notice that the beta subunit is bigger than the alpha subunit. Can you see? Yes. And we have got disulfide bond between alpha and beta subunit. In case of hCG, there is a non-covalent form of bondage between alpha and beta. We do know from our knowledge of biochemistry that covalent bonds are the strongest. Okay, but it is the non-covalent form of bondage which is present between two subunits of hCG. Okay, so it can be like disulfide bond. It is also like ionic bond and the hydrogen bond. What I mean to say is this: in between alpha and beta subunit, we have got a non-covalent bond, which is a weak bond. So alpha and beta subunit of hCG can be, they are separable easily. Okay. Now, there is a very peculiar feature in beta subunit. What is that? We have got a terminal sialic acid compound attached to the beta subunit, and this terminal sialic acid compound, okay, now this terminal sialic acid compound inhibits the breakdown or catabolism of hCG. So if it inhibits the breakdown or catabolism of hCG, it is going to increase the lifespan. Okay, so despite of having an enormous similarity in the structure, if you notice the T half, which is the half-life of hCG and LH, they are significantly different just because of this particular component, which is terminal sialic acid. Because of this, the half-life of the hCG is approximately 36 hours, and the half-life of LH is approximately 2 hours. Am I clear? So alpha and beta subunit linked with each other by disulfide bond. Beta subunit has got a peculiar feature. They are having a special component, which is this. They are the terminal salicylic acid component. This terminal salicylic acid component, which is attached to the beta subunit, they inhibit the breakdown of hCG, thereby increasing the half-life of hCG. Okay, and because of this component, the half-life of hCG is 36 hours and half-life of LH is only 2 hours, despite of having enormous structural similarity. Am I clear? Now, there is another very special thing about the structure of hCG, and this is the fact that the alpha subunit is a non-specific subunit and beta subunit is a specific subunit. Alpha subunit is non-specific because it has got a structural similarity with the alpha subunit of 3 anterior pituitary hormone. They are FSH, LH and TSH. So we have got 2 gonadotropin, right, and another is TSH. Am I clear? Now, beta subunit is specific, right? When I say specific, I mean it is specific to pregnancy. It is also specific to a very rare form of ovarian cancer. We call it ovarian choriocarcinoma. So the marker for ovarian choriocarcinoma is beta hCG. But generally speaking, when I say it is specific, I mean it is specific to pregnancy. Alright? And it is the basis of performing UPT. So when you do UPT or a card test, right, even for a blood test, we measure the beta hCG, right, if the patient is suspected to be pregnant or in case of a pregnant lady. Okay, now I want you to focus on the screen now and just focus on this part I'm marking. Okay, just focus on this part. Okay, now I told you that the alpha subunit of FSH, LH and the alpha subunit of hCG, they are same. Okay, they have got similar structure, non-specific. Okay, now it has got 3 very important clinical implications. What are those? First one is hyperemesis gravidarum. First one is hyperemesis gravidarum. Second one is bilateral theca lutein cyst, and third one is ovulation trigger. So because the hCG has got structural similarity, okay, with the gonadotropins released from the anterobutary gland with subunit alpha, it has got 3 very important clinical implications. First, hyperemesis gravidarum, second, theca lutein cyst, and third, ovulation trigger. Let's go one by one. Now I first wanted to focus on this, okay, that is your bilateral theca lutein cyst. Now, as because the alpha subunit of FSH and LH is same as that of hCG, it basically, stimulate the ovarian follicles and causes bilateral theca lutein cyst. Now, see this. I want you to focus on this picture. So this is the intraoperative picture of bilateral theca lutein cyst. They are usually bilateral. They usually grow very rapidly. Okay, and they're usually huge in size. And as they're huge in size, there is increased risk of rupture and torsion. If at all there is rupture or torsion, those are absolute obstetric emergency, so we need to intervene surgically. All right. Just I wanted to focus on this picture right now. So what you can see in this picture is a blastocyst which is getting implanted. If you see the structure or anatomy of blastocyst, so it has got an outer cell layer and it has got an inner cell mass. Okay, so this is the outer cell layer right over here, and then we have got the inner cell mass. Now this outer cell layer, they form placenta, and the inner cell mass, they form the fetus. Am I clear with this? Now this outer cell layer, they further get differentiated into inner sideroblast and outer sideroblast. So this is your sideroblast and this is your sideroblast. And as we know, a multinucleated animal cell is called syncytium. Okay, and troblast means again something related to the placenta. Okay, so that's why it is called syncytiotroblast. All right, fine. So we have got a very high yield box over here. Now I already told you that the alpha subunit is a smaller subunit and the beta subunit is a larger subunit. B for beta subunit, B for beta subunit. Okay, and the alpha subunit is non-specific. It has got similarity with 3 anterior pituitary hormones. Those are FSH, LH, and TSH. On contrary to that, the beta subunit is specific, and it is specific to pregnancy. Okay, now, so thecal uterine cyst is seen if the lady is having excessively high level of hCG. Okay, so what are the conditions? Those conditions can be multi-fetal gestations like twins or triplets or quadruplets, or it can be molar pregnancy, especially if at all it's a complete molar pregnancy. Am I clear with this? Then because of those similarity with these two gonadotropins, it also leads to hyperemesis gravidarum. Okay, especially again if the beta hCG level is very high. Okay, as in case of multifetal gestation and molar pregnancy. Okay, then because it has got similarity with the alpha subunit of LH hormone, luteinizing hormone, it can be used, or it is used as a ovulation trigger as well. Am I clear with this? Okay, so we have got 3 clinical implications because it has got similarity with gonadotropins as far as the alpha subunit is concerned: hyperemesis gravidarum, bilateral thecal uterine cyst, and ovulation trigger. Okay, now, okay, and the mnemonic is here HOT. Okay, so hyperemesis gravidarum, ovulation trigger, and thecal uterine cyst. Am I clear with this? Then I told you that it has got similarity with TSH as well as far as the alpha subunit is concerned, and that's why when the hCG level is very high, it can also lead to hyperthyroidism and thyroidoxicosis, right? Especially in case of twin pregnancy or triplet or quadruplet, I mean to say a multi-fetal gestation and molar pregnancy. Am I clear with this? So you have got only 1 clinical implications as far as the similarity with TSH is concerned. Am I clear with this? Okay. And just to complete the topic, as you can see it here, the alpha subunit is encoded by 6q and the beta subunit is encoded by 19q. Okay, so we know that chromosome has got 2 arms. We have got a small arm and long arm. Small arm is called P arm and long arm is called Q arm. Okay, now P stands for petit. Petit is a French word which means small or short, Okay, Q doesn't mean anything. It's just because the alphabet which is next to P is Q, we use Q. Q doesn't mean anything just because, like, Q comes after P, we call it Q. Okay, so P is a French word which means petite, which means short or small, and as Q comes after P, we use Q to denote, or to refer to the long arm of the chromosome. All right. Okay. So yeah, we have gone through this picture. Now let's talk about the mechanism of action of hCG. I told you already, it's a glycoprotein. All right. And if a hormone is is a proteinaceous in nature, or peptide hormone, right, being charged, they cannot cross the cell membrane. So their receptor has to be a membrane bound receptor, which is exactly right as in case of hCG. So I want you to focus on this beautiful picture. Now see, the receptor for hCG is called G protein coupled receptor, which is also known as the 7-pass receptor or serpentine receptor. Am I clear with this? And this receptor is called LH-hCG receptor. It is also called LHGCR receptor. Okay, now because this receptor, right, binds with both LH as well as hCG. Now if we decode this terminology, we have got LH, we have got hCG, we have got R. So in short, we call it LHCGR. It is encoded by the same gene. This is LHCGR gene. Am I clear with this? Now, when the hCG binds with this receptor, okay, it is inside the cell, it is attached to GS. Okay, GS stands for G stimulatory. All right, so that GS has got 3 subunits. We have got alpha, beta and gamma. Whenever the beta hCG binds with this receptor, the alpha subunits get separated from its beta and gamma subunits, getting energized, and the source of energy is being your GTP, converting into GDP and PI. All right, so when this whenever the alpha subunit of GS gets stimulated, it converts ATP into AMP, cyclic AMP. Okay, with the help of enzyme adenyl cyclase, which is present on the cell membrane. Excuse me. Now this cyclic AMP is a secondary messenger over here, and it converts protein kinase A to activated protein kinase A, and this activated protein kinase A is going to phosphorylate different functional proteins of the cell. Alright, so whenever you have got this suffix, okay, like kinase, alright, the function of the kinase is to phosphorylate other proteins. That's it. And on phosphorylation, now some group of proteins, they can get activated, and the other group of protein, they might get inhibited. Alright, so that is the basic mechanism of action of hCG. The receptor is G protein coupled receptor. It is bind with the GS. The receptor itself is called LH-hCG receptor. Right, the secondary messenger is being the cyclic AMP, which is going to activate protein kinase A, right, and it is going to phosphorylate different cellular protein. All right, and shows its biological function. Am I clear with this? Done? Okay. The last part of this discussion is the dynamics of hCG. It is the most important part of this discussion. Now, I want all of you to focus on this very important graph over here. Now, if you see this graph, okay, before discussing this graph, let me discuss something very basic with you guys. You know what? Until like 10 weeks of gestation, beta hCG, or not beta hCG, I would say like hCG, human chorionic growth or hCG, act as a savior of corpus luteum. We call it corpus luteum rescue, okay, because hCG helps in rescuing corpus luteum. Okay, now if there is pregnancy, okay, progesterone is the most important hormone for implantation and maintenance of pregnancy, and the source or the factory of progesterone in the early months of pregnancy until 10 weeks to be specific is principally corpus luteum. Okay, so the corpus luteum should be saved, and this function is being done by hCG. Am I clear? If at all, right, there is no fertilization, there is no pregnancy, the corpus luteum lives inside the ovary for about almost 12 days. Okay, so if a female is having a menstrual cycle of 28 days, on day 14 ovulation occurs, right? Once the Graafian follicle ruptures, okay, after ovulation, during ovulation, what really happens? Once the Graafian follicle ruptures during ovulation, the Graafian follicle is converted into corpus luteum. Corpus luteum then stays in the ovary for about 12 days. If at all there is no fertilization, after 12 days it undergoes degradation and degeneration, and the denatured corpus luteum is then being called corpus albicans. Now this corpus luteum is basically this terminology is coming from a Latin word. Corpus means body and luteum means yellow. So as the gross appearance as well as the microscopic appearance of corpus luteum, is yellow, we call it yellow body or corpus luteum. Corpus albicans similarly means a white body. Albicans means white and corpus means body. So once the corpus luteum undergoes, degeneration, this degenerated corpus luteum is then being called as corpus albicans. Okay, so that is the scenario. But the lifespan of corpus luteum, if there is fertilization, is 10 weeks. After 10 weeks, ovary, communicate, the corpus luteum of ovary communicate with the placenta that I have done my part, now it's your turn. Now you should take over the job of producing progesterone, because we need progesterone throughout the pregnancy. Progesterone is the most important hormone which maintains uterine quiescence. Okay, it keeps the uterus relaxed. Okay, so we need a constant supply of progesterone, okay, for a successful maintenance of pregnancy. So for the initial weeks we need progesterone, and progesterone is being supplied by corpus luteum. And who saves corpus luteum? It is the hCG. I told you already, hCG has got similarity with the FSH and LH as far as the alpha subunit is concerned, and thereby they help in corpus luteum rescue. This is number one. After 10 weeks, it is the placenta which is the principal factory for producing progesterone. Okay, so if you can see this graph, right, and then throughout the pregnancy, it is after 10 weeks, rest of the pregnancy, it is the placenta which is producing progesterone in substantial amount. Now if you see this graph, so we can see that there is a sharp rise of hCG, and the hCG hits the peak level at 10 weeks. This is very important, 10 weeks. So at 10 weeks we have got a peak, okay. Excuse me. Then there is a sharp decline. Then there is a sharp decline which is followed by a plateau, and then there is a small peak at 32 weeks, then again plateau, and then there is gradual decline, then there is gradual declination of hCG following delivery. Am I clear? So just let me revise it again with you guys. Now can you see there's a sharp rise of hCG because hCG is important, hCG is needed for corpus luteum rescue, and it hits the peak level at 10 weeks. After that there's a sharp fall and it hits the plateau at 16 weeks. From 16 weeks onwards is a plateau, right, throughout the pregnancy. Only there is a small peak, a very small peak at 32 weeks, and after delivery there is gradual fall of hCG followed by normalization of hCG. So when do we call, at which serum level we call that like beta hCG is normalized? So when the level of beta hCG is 5 or less, we call it the beta hCG level is normalized, okay. So it has to be 5 or less. All right. Now we should ask ourselves a question, that after how many days the normalization of beta hCG level occurs, right? And we have got 3 different scenarios. So if we talk about the vaginal delivery or abortion, be it spontaneous abortion or be it medical termination of pregnancy, the beta hCG level get normalized like within 2 weeks. All right. After cesarean section, it takes a little bit higher time to get normalized, that is 3 weeks, okay. And in case of molar pregnancy, when we do suction and evacuation, it takes around 8 weeks, okay. It is the right. Now this 8 weeks is the average, okay. In case of complete mole, it takes a little bit higher, that is 9 weeks. In case of partial mole, it is 7 weeks, but on average or the mean is 8 weeks. Am I clear with this? So here I want you to remember a digit, right? That is 238. Okay, I want to remember this digit 238. So 2 weeks for VD and abortion, 3 weeks for cesarean section, and 8 weeks for molar pregnancy. To be specific, for complete mole complete mole add 1, and for partial mole subtract 1. Okay, so that is very, very important. I have already told you this, how it really acts and all. Okay, now the last aspect of this is, I told you that having similarity with the FSH, LH, the hCG causes hyperemesis gravidarum. But how? So the nausea in pregnancy or hyperemesis gravidarum, it has got a this entire entity is multifactorial. So we have got like hormonal factors, genetic factors, GI factors, infections, immunological factors, a lot. Okay, but let's understand how it really causes nausea in pregnancy as well as hyperemesis gravidarum when the level of hCG is very, very high. Now the vomiting center is present in this part of the brain. Okay, in this part of the brain, this is called medulla. Okay, so this is the brain, so this is the midbrain, this is the pons, this is the medulla. Okay, and in this part of the brain, we have got our vomiting center. We call it CTZ, and it's also called, the full term is being chemoreceptor trigger zone. Now, hCG is basically activates this particular vomiting center. Now, the peculiar thing about this vomiting center is this: it is present in that part of brain which is not a very well secured zone. What I mean to say is this: this CTZ is present near a region called area postrema, and in this region the blood-brain barrier is broken. Okay, so this center is easily influenced by different hormones and neurochemicals. Okay, now, so that is one reason, right? So hCG directly activates the chemoreceptor trigger zone, causing nausea-vomiting pregnancy or hyperemesis gravidarum if their level is very high. Okay, and can you see this? The peak time for hyperemesis gravidarum is 9 to 12 weeks. Okay, I told you that the hCG hits its peak level at around 10 weeks. Okay, so it is also matching that. Next, you know what? The hCG, okay, it stimulates the corpus luteum to produce estrogen. Okay, because it has got similarity with the FSH and LH. Okay, so hCG stimulates corpus luteum to produce estrogen. So not only the corpus luteum produces progesterone, it also produces estrogen. Now, this estrogen and progesterone, they are coming from corpus luteum, and corpus luteum is being stimulated by hCG. Okay, now understand this. Now, estrogen acts synergistically with the hCG. They are basically complementing each other's action. Now, we all know estrogen basically decreases the gastric emptying time. Okay, thereby increases the risk of hyperemesis gravidarum as well as nausea, vomiting in pregnancy. We do know progesterone has got a smooth muscle relaxant property, and thereby progesterone, delays the gastric emptying as well. And whenever the gastric emptying time is getting delayed, there's increased risk of hyperemesis gravidarum because of increased intragastric pressure. Right? I already told you this, right? Increased level of hCG, increased risk of, hyperthyroidism or thyrotoxicosis, and even in case of thyrotoxicosis, there is hyperemesis gravidarum, right? And sometimes also in patients with hyperthyroidism, we do get hyperemesis gravidarum. All right. So these are the mechanisms by which, these are the four mechanisms by which hCG causes nausea-vomiting pregnancy as well as hyperemesis gravidarum. In next part, we're going to discuss the function of hCG in extreme detail, with special mention to the immunomodulatory effect of hCG, and that session is going to be super interesting. Thanks a lot for your patience. Thanks a lot for your patient hearing, and just comment down below about your different queries, and if at all you have got any questions, I'll be more than happy to answer those. And as always, have a great day. Bye bye.